Well, thank you very much, Jason. Yeah, so as Jason mentioned, I'll be here to talk to you a little bit about some of the opioid stewardship that we delved into this past year. So I'm pleased to present to you Breaking the Slow Release Habit, Opioid Stewardship, Quality Improvement Following Arthroplasty in a Small Hospital. There we go. Okay, so just reviewing SHA's vision, mission, values, and philosophy of care. So stewardship falls very much into the values of accountability, respect, compassion. I mean, stewardship is so important. And also, I don't know that anybody, I'm really happy to have this platform to tell you that if you rearrange the CARES values in SHA, it actually can also spell scare. So I'm glad that we chose CARE instead of scare. All right. We acknowledge that we are gathering on treaties 2, 4, 5, 6, and 8, and 10. We did a Assiniboine, Nakota, and Saulteaux territories, and the homeland of the Dakota, Lakota, and Métis. All right, today, hopefully I'll be able to provide you some tips about how to get started in quality improvement, and illustrate some examples of plan, do, study, act, and how a flexible mindset can be an asset in quality improvement. We'll review the results of the project and describe some of the real life results and future work that came. All right, so it all started with a student. Step one for quality improvement is get outside your comfort zone a little bit. So we decided to offer our very first non-direct student rotation in Lloydminster this past year. I was pretty nervous about it. I thought it would be this like rigorous research-based kind of rotation. Because I remember, when I worked in Regina for my residency, we had like a statistician on staff that could work with us. And I thought that that's what projects had to be in the health region. It can be that, but luckily I had some excellent examples of how it doesn't have to be that. So thanks to Kelsey and Tanya, they're from Yorkton. They've shared a couple of projects with me that showed me, oh my goodness, like we can do quality improvement projects with students in a smaller center that don't have to be statistically powered correctly or have a lot of math involved. They can just be projects that we think we need to do in our smaller centers. And just go, even if you don't think you have the expertise, go for it. So yeah, and since then I've seen lots of other exciting rural projects. Swift Current does amazing things. North Battleford, I mean, PA, everybody's doing some wonderful work. So yeah, get outside your comfort zone. You don't have to be a fancy researcher to do quality improvement. Step two, get some stakeholder input. So I emailed our student that was coming for our non-direct rotation. Her name was Ryder Milne. She was amazing. And I gave her some suggestions of projects that we could work on. And then I asked her to rank them. And then I asked her if she had any project ideas that she would like to work on. So apparently there actually is a world outside of antimicrobial stewardship, because she emailed me and said, as another potential project interest, it would be intriguing to look into post-op opioid prescribing. We had a guest speaker in to talk about opioid stewardship and how many patients received their first exposure to opioids following surgery, with the most common post-surgical complication of becoming a new chronic opioid user. As she stated, prescription size is the strongest predictor of how much opioids a person will use. So yeah, Ryder had an interest in opioid stewardship. So step three, find the right people. She said, we had a guest speaker in to talk about opioid stewardship. I think I know who that was. It was Kelsey Dumont. Now, luckily for me, Kelsey, you did not know that these pictures were going to make it into this slide deck, so I am sorry. I've known Kelsey for a little while, so this is pictures from our gymnastics adventure yearbook circa around 1996. So as you can see, there's little me on the left there, and there's Kelsey also on the right-hand side picture. So Kelsey was a little bit older than me and far better than me at gymnastics, but we actually were gymnasts in the same gymnastics club back in Regina. And for the younger pharmacists on the line, when I was 8 years old in 1996, there actually was color photos were invented, like they were available. these are just black and white because our club was too cheap to print their yearbook on and color printing. So yes, I am old enough to have color photos in my past. I'm not that old. Anyway, so yes, I knew Kelsey. So Kelsey and her colleague Leland Summer came to Lloydminster in August of 2025. So they're from the Stewardship and Clinical Appropriateness Department. I always forget. I see Kelsey nodding, something like that. That's the department that they are working for. So they came to Lloydminster and they came to our hospital for a day. And they provided education to the pharmacy and to some non-pharmacy staff about opioid stewardship. They kind of toured around the hospital just to kind of get a better feel of how we do things, what our processes are, what our culture is. And they worked with us to formulate a project that Ryder would be working on in the fall. So we formulated a project that was very similar to what the opioid stewardship team in Regina was doing. So they use a PAR tool to identify patients who might be at higher risk for opioid toxicity. Now, I'm sure you've all heard about the PAR tool from other presentations, but kind of the long and the short of it, as I understand it, is they pull certain parameters from BDM to be able to make themselves a list of patients that would be worth their while to see in Regina hospitals. And a huge shout out to the analysts on the stewardship team. They do amazing work, which I don't understand. So thank you for being there. And so, yeah, anyway, Ryder, we made this project where Ryder was going to use this PAR tool, and they actually were able to set up Lloydminster data that would like filter in so that we could see it and we could choose our patients based on our patient parameters in Lloydminster Hospital. So once identified, Ryder would apply the MORE tool to optimize opioid use and pain control in the identified patients. And there's just a little image of the MORE tool on the right there. If you haven't seen it, check it out. It's a really nice way for a practitioner who's not a specialist in pain control to go through and assess a patient and maybe make some recommendations. All right, so keep getting your collaboration on. Kelsey and Leland had frequent check-ins with us. They helped us with some consultation on tricky cases, and they kind of helped us discuss the differences in process between tertiary and rural, what that looks like. And Kelsey did a few therapeutic discussions for Ryder and our other student and for me. So it was just really nice to have the stewardship team available to help with this rotation because they are the experts. And as it turns out, nothing works the way that you think it will. So this is where we had a little kind of a PDSA going on here. So Ryder was doing some really great workups using the MORE tool. But we found that the PAR tool, which was the tool that was used to identify patients that we should go see, wasn't really working very well. It wasn't working the same way for us as it did in tertiary. What we found is that in the tertiary care center, when there's so many patients to look through and you have a specialized pain team to go in and look at those patients, the PAR tool identified high risk, complex patients that we felt in the rural center, we weren't super equipped to manage. So we kind of changed our strategy so that we could look more at patients who were just needed kind of like your generalized care and attention stewardship interventions. So we actually changed how we were doing things. We changed how we are identifying patients, which just kind of underlines how things that work in tertiary can still work in rural, but they just might need a little bit of tweaking. So all that being said, this is kind of the history of how Ryder got to Lloydminster and why we chose opioid stewardship as a project. But this project's kind of a story for another day. Just kind of what I wanted to underline is we got Ryder here. She was looking at opioids, but having a flexible mindset actually allowed us to take on a different kind of project, which is actually the project that I'm going to talk to you about today. So how did this current project come into being? So while keeping flexibility in mind, one day, and this is about in the middle of Ryder's rotation, we were walking in the OR looking for a physician, and we saw Dr. Wheat Hozak, who was the surgery team lead. So let's pause for some backstory here. The backstory. So the provincial post-operative arthroplasty order set came out recently. Now, on that order set, hydromorphone SR 3 milligrams by mouth BID was not listed on the order set. Now, that was a very big change in practice for our physicians here in Lloydminster. They routinely, unless there was a contraindication, they routinely gave an SR dilaudid, either 3 milligrams or 6 milligrams, to every patient who was receiving a an arthroplasty, a hip or a knee. And with the intention that that kind of just keeps pain under control for the first couple of weeks after surgery so that the patient can, they can leave the hospital, they can have their physio being optimized and all that kind of stuff. So then this new order set came out that didn't have the SR formulation on it. So our physicians continued to write in the SR formulation because they really liked it. They kind of thought, if it's not broke, don't fix it. Which, I mean, in general, I think that's a really great mantra for a surgeon to live by. If it's not broke, don't fix it. But in this case, we could fix this. And when Kelsey and Leland came in the summer, they did mention that they had discussions, because we kind of asked them, like, why are our surgeons doing this? And why didn't it show up on the provincial order set? And they said they kind of had discussions with our physicians about the SR formulation, about how maybe it wasn't optimal. But our physicians chose to keep prescribing it. They were citing excellent pain control and facilitation of rapid discharge with this SR formulation. So why was the provincial team so interested in having us not prescribe the SR formulation? And, if there's lots of questions at the end, I'm sure Kelsey or Leland would be able to answer them a little bit better, but I did rip off some of their slides here. So I'll just kind of give you a little bit of the reasoning. So when we look at opioid use and risk of continued opioid use after the first opioid is given, one of the risk factors for continued opioid use is actually the amount of days that the patient has an opioid. So this little graphic here is just showing a study that was done, looks like 2015, where they looked at the duration of the initial opioid prescription that a patient had, and then they looked at the risk that the patient would still be taking opioids at both 1 year and 3 years. So what they found out is that if patients that the risk of chronic opioid use increases after just 3 days of having opioids. And the risk is about 14% if the patient is using opioids for 8 days, and goes up to almost 30% if the patient is using an opioid for up to 1 month. So what we can take from this table is that, oh yes, thanks. Kelsey's just giving a little bit more information, some backstory for this this table. So thank you, Kelsey. Yeah. So what we can see is that the likelihood of chronic use increases with each additional day of opioid therapy. And as we know, chronic opioid use equals the risk of overdose and opioid use disorder. So I actually just took a little quote from this paper that also kind of gave a little bit more context for why the SR discussion is so important, which said the highest probabilities of continued opioid use at 1 and 3 years were observed among patients who initiated treatment with a long-acting opioid, 27.3% at 1 year and 20.5% at 3 years. So what I'm getting from this is we should try to avoid using long-acting opioids, especially right from the get-go, as much as we can. So what are the risks, especially in the post-operative setting, of using an SR opioid? So pharmacokinetics just make safe titration of the SR products challenging, if not impossible. Especially post-operatively, those pain needs are changing from day to day. So to use an SR formulation that requires titration over at least a 24-hour period is not optimal. We see higher rates of adverse drug events, increased length of stay, and higher readmission rates in those who are using SR opioids. And then again, just as we described in the last slide, persistent post-operative use of opioids is a risk, especially with SR opioids. And I found this little nugget here that those prescribed an SR opioid were twice as likely to experience accidental overdose, which occurred more frequently in the first 2 weeks of therapy. So to me, those are all a ton of risks that I don't really want to take on if I don't have to. But efficacy, can we counteract those risks with increased efficacy? Well, there's a question mark on that slide for a reason. So something about post-operative pain that I'd never really thought too much about in the past was that constant analgesia is not really required and is not really appropriate for the post-operative pain patient. So the goal of pain control post-operatively, in general, is to support activity and function. So we're looking at quite a lot of pain with intermittent exacerbations associated with activity or physical therapy, and we want to support pain control at those times. But in general, patients post-operatively, in general, don't experience a ton of very extreme pain all the time. It's usually associated with that incident pain of movement, physio, that kind of thing. And the way that it was described to me by Kelsey and Leland in the summer, it just really resonated with me. They kind of described a simmer effect. So if you take a dose of SR hydromorphone and it's supposed to be good for 12 hours, and you divide the actual dose of hydromorphone over 12 hours, we're getting about 0.25 milligrams of hydromorphone per hour. And is this actually enough to treat acute post-surgical pain? And the argument would be no, it's not. Canadian guidelines also, and many guidelines that I reviewed when I was looking at this presentation, suggest actually against SR formulations for post-operative pain. So there's a lot of information telling us we probably shouldn't be using SRs in the post-operative setting. Okay, so back to the story. One day we were in the OR talking to Dr. Wheat-Hozak. So we actually were talking to her about the SR formulations, and I kind of described the simmer effect as Kelsey and Leland had explained it to me, and that really seemed to resonate with her as well. Not to mention that the doctors had been primed for maybe taking away the SR formulation from previous discussions they'd had with the provincial team. So they did they were consulting when that order set was being made. They kind of knew that they were some of the only practitioners in the province that were using the SR formulation in the post-operative setting. So the provincial team had primed them. They just needed one little extra step from a local team to say, hey, maybe we should try this. So Dr. Wheat-Hozak did have some reservations. She didn't think that we would get as good pain control. And so because we had a student and Ryder was super gung-ho, we offered to do kind of a pre-post study. So we offered to look at several different parameters of patients who had received the SR. And then, starting next week, Dr. Wheat-Hozak agreed that no patient would receive the SR. And we would look at those patients who didn't receive the SR and compare them. So Ryder got right to work making a red cap tool. Luckily, she'd been using the red cap for the project that she was already here in Lloydminster for. So she whipped that up really fast all by herself. So great work, Ryder. And luckily, I caught one of the other orthopedic surgeons, Dr. Kowalczyk, in a stairwell, and we're kind of talking about this. And he said that his big concerns was length of stay. Because there's so much bad pressure. We want to make sure that if we're doing surgery on these patients and they're supposed to be gone the next day, that they actually do get out of the hospital the next day. He didn't want patients to be, gunking up the system by presenting back to emerge or presenting to the hospital or to the physician clinic due to pain problems. So we did add these parameters to our data collection as well to make sure to kind of satisfy his concerns as well. All right, so what did we find out? Results. Ryder examined 31 charts. 17 of the patients had received an SR opioid and 14 did not. And this is just kind of the reason there's uneven numbers is just by the time we got to actually removing the SR opioid, Ryder only had a couple of weeks left in her rotation. Whatever the case, we found that the average length of stay was similar between the two groups, so 1.2 days for both groups. No patients in either group had an unscheduled presentation to hospital or clinic after discharge, be it for pain or anything else. Now, one thing that was a little bit different that I'll just throw out there for transparency's sake is that when we think about the expected length of stay being 1 day, the average length of stay between the two groups was similar, but we did find that actually one extra patient in the no SR group stayed for more than 1 day, so stayed for more than the expected length of time. So that was 21% of patients in the no SR group versus 12% in the SR group. But just to give some context, I wanted to show you why these patients stayed in the hospital for an additional day. So in the no SR group, one of the patients fainted during physio and experienced hives. One of them struggled with nausea and vomiting and requested to stay another night. And one of them just could not comprehend the physio's instructions. They had a history of dementia. In the SR group, the 2 patients that stayed for greater than 1 day, one of the patients suffered from post-operative delirium. Again, this was on a history of mild dementia. And one of the patients had absolutely no supports at home and actually required transfer to a smaller hospital in the area for convalescence. Okay. So pain control. Did we see a big difference in pain control between the SR and no SR group? So when we look at are we actually getting the patients functional? Are we getting them to do their physio so that they can get ready to go home and to get better? When we looked at patients who delayed their physio due to pain control, actually 0 patients in the no SR group delayed their physio, whereas 6 patients or 35% of patients in the SR group had to have their physio delayed due to pain concerns specifically. When we looked at average pain scores for the patients throughout their stay, now take this one with a grain of salt. It was kind of hard to find pain scores. Sometimes they were sort of inconsistently documented in the chart, but whatever the case, we did find that the average pain scores for patients who did not receive an SR opioid were about 3.4. Whereas they were 6.5 in the patients who did receive an SR formulation, which is kind of opposite what I would have thought. I would have thought, more opioids would equal better pain control, but it did not in our particular patients. Then we looked at the average total oral morphine equivalents consumed. So how much opioid did these patients actually get? Just keeping in mind that our usual SR order that we were giving patients post-operatively was 3 milligrams of hydromorphone SRP, which is equivalent to 30 oral morphine equivalents per day. And we did find that in the no SR group, we had an average of about 25 OMEs per day, whereas in the SR group, we had an average of 65 OMEs per day. So just thinking about that, if we look at the previous slide, so our no SR group actually had lower pain scores with about half of the morphine equivalents consumed. That was interesting and surprising to me. And just kind of just a shout out to remember, our surgeons were very, very compliant with the provincial order sets. So all of the patients in all of the groups received scheduled acetaminophen. All of the patients, except for one, received NSAIDs. All had immediate release oral opioids available, and about half of them had parenteral opioids as well. So there was a lot of non-opioid adjuvant pain medication that was being used in these patients, which was nice to see and in keeping with opioid stewardship principles. So what do we learn? In our small study, eliminating routine SR opioid use resulted in no change in average length of stay, nor any additional presentations to the physician after discharge. Better pain control and the ability to engage in physical therapy, less average daily oral morphine equivalents consumed, but we could say, in at least in our study, there were possibly more patients who exceeded the target length of stay, which was 1 day. But none of these delays were due to pain. Are they surprising, these results? Well, they were not surprising to Kelsey and Leland. Previous studies, larger than ours, described those receiving SR opioids in the post-operative setting having higher pain scores and having more oral morphine equivalents consumed. So larger studies and kind of around the 500 patient mark found exactly what we found. Why were the pain scores worse? I mean, and this is just kind of spitballing between Kelsey and I. Possibly there was a reluctance to give additional opioids for incident pain as the patient was already getting an SR. Maybe we didn't want to give too much opioid from a nursing perspective, or maybe kind of from a nursing perspective, maybe almost forgetting about the pain, thinking, oh, well, they're on an SR, they're covered, they shouldn't need any more pain control. But that actually was not the case for the patients. What did we do with this information? So I sent a quick email to Dr. Wheat-Hozak, the head of surgery, who distributed it to our orthopedic surgeons. And we are lucky in this small rural setting. We have 3 orthopedic surgeons. So getting them all on board for this intervention and distributing the information to them was very, very easy. I also shared it with a surgical nurse educator who shared it with her nursing staff as well. So now I can say to this day, our orthopedic surgeons no longer routinely prescribe SR opioids during admission or at discharge after their hip or knee arthroplasties. Now that if a patient came in on an SR, we wouldn't stop it, but they're not giving it just for the reason of postoperative pain. And some of them actually don't even use the parenteral opioids anymore. So this is just a little screenshot of an order that I received when I was working on this project yesterday of one of the order sets from our physicians. Yeah, so he's got the hydromorphone. And this surgeon actually used to write for PO hydromorphone, IV morphine, and the SR dilaudid. So now he's kind of pared that back. He's in on the naloxone thing, which is another great opioid stewardship intervention. And then he's actually only prescribing the oral hydromorphone tablets, the IR tablets as needed. And he has been doing this for a while. So he's obviously been finding some success with this strategy. The benefits of this project, well, hopefully we have reduced the risk of adverse events, persistent opioid use, and toxicity for our patients in Lloydminster Hospital. And each hydromorphone 3 milligram SR capsule is about 57 cents. So we have saved tens of dollars since the summer on drug costs alone. What else is there to do? So the age-old question, how do we translate a student project into everyday practice? So luckily for this particular intervention, we've been successful in causing a sustained change in practice, which is not always what you see, especially with a student project. But we do, so the student project that Ryder actually came here initially for, just kind of like opioid stewardship in Lloydminster Hospital, we do have lots that we can do with that. So I do have so our education, I'm lucky enough to be able to participate in our nursing's annual all-day education sessions. So opioid stewardship will be the focus for this year for our nurses. Our hospitalist team is going to have me in a few months to talk about opioid stewardship as well. And they were actually even just talking at our last team meeting yesterday. They were like, how do we get these naloxone orders on all of these patients? So we're kind of doing some exploring there. So there's lots that we can do from the nursing perspective, from the physician perspective. I'd like to discuss maybe putting opioid stewardship on the forefront for our interdisciplinary rounds. But we'll kind of see how that goes because you have to pick and choose what you want to do there because it's such a small time period. So there is a lot we can do. At least we kind of know from Ryder being here what opioid stewardship interventions would be the easiest for us to implement here in Lloydminster Hospital. But that's, again, a talk for another day. So in summary, a small quality improvement project changed practice for 3 physicians. And this was built on the back of provincial messaging. And again, I am just very delighted to have discovered that you don't have to be an expert to be usually I'm saying antimicrobial at this point, but you don't have to be an expert to be an opioid. That is everything. Comments.
That'll help. Thanks. Thank you, Kat. That's fantastic. I'm going to stop the recording here and then